Hello, my name is Juliet Jordan Joseph. I'm a clinical pharmacist and a 2015 graduate of the Masters in Diabetes Education and Management program. Today, we're going to review a class of diabetes medications called Biguinides. I'll give you a brief overview about the history of biguinides and then we'll discuss their pharmacology. In the 20th century, a compound called guanidine was extracted from the French lilac plant, also called goat's rue, and it was found to have anti-hyperglycemic properties, but it was too toxic for clinical use. In the 1920s, researchers in Germany synthesized a drug called synthilin, which is structurally similar to guanidine, but its use was short-lived because of hepatotoxicity and nephrotoxicity. During this period, biguinides were being researched, but the study and the development of new insulin products dominated that era, so biguinides were placed on the back burner. Then in the 1950s, biguinides made a comeback. In 1957, fenformin was introduced in the United States, and that same year, metformin was introduced in France, and in 1959, buformin was introduced in Germany. However, after fenformin and buformin were found to cause lactic acidosis that resulted in several deaths, they were withdrawn from the market. However, the risk of lactic acidosis was found to be rare with metformin. Although metformin was used in other countries since 1957, it was not FDA approved for use in the United States until 1995. It is the only biguanide that is available to treat hyperglycemia in the United States. After numerous studies revealed that metformin reduced the risk of MIs and all-cause mortality, it became the drug of choice to treat hyperglycemia in patients with type 2 diabetes. The standards of medical care in diabetes encourages the use of metformin in patients with prediabetes also. Now let's discuss the mechanism of action. Metformin works primarily by decreasing hepatic gluconeogenesis, which means that it diminishes hepatic glucose production. It also decreases glucose absorption from the GI tract, and it improves insulin receptor sensitivity. Now, since people with prediabetes and type 2 diabetes tend to develop insulin resistance, metformin is an excellent choice for them. Metformin may be dosed once daily or twice daily. In adults, you may start off with a low dose of 500 milligrams twice daily or 850 milligrams once daily with meals. Then you would increase it in increments of 500 milligrams once weekly, and then or 850 milligrams every 2 weeks. The maximum daily dose for metformin is 2,550 milligrams. Now let's review the pharmacokinetics. 50 to 60% of metformin is absorbed when a 500 milligram tablet is taken in the fasting state. Taking it with food may reduce GI side effects, but food delays absorption and decreases its bioavailability. The peak concentration is about 40% lower when it's taken with food. Metformin reaches steady state in 24 to 48 hours. It has a half-life of 6.2 hours in plasma and 17.6 hours in blood. It distributes into erythrocytes and it is not metabolized in the liver. Roughly 90% of the drug is excreted unchanged in the urine. In 2016, the FDA published revised guidelines for prescribing metformin, and it included using metformin in patients with reduced renal function. These updates were visible in product labeling in 2017. Previously, we used the serum creatinine to determine when to stop metformin. The serum creatinine cutoff was 1.5 in men and 1.4 in women. But now we use the EGFR, which is the estimated glomerular filtration rate, to determine if it is okay to start, continue, or discontinue metformin. The EGFR should be drawn before prescribing metformin and should be repeated at least annually. You can initiate metformin if EGFR is greater than 45 mL per minute. However, if someone is taking metformin and has an EGFR between 30 and 45 mL per minute, you can weigh the benefits or risk of keeping them on metformin. But its use is contraindicated if EGFR is less than 40 mL per minute. Now, there are several benefits to using metformin. It's safe, inexpensive. It may reduce the risk of cardiovascular events and death. It doesn't typically cause hypoglycemia when used alone. It doesn't cause weight gain and may promote weight loss, and it yields about a 1.5 percentage point decrease in A1C. However, it does have side effects. It can cause B12 deficiency, so you would definitely want to look for that. And it can cause an array of GI side effects such as nausea, vomiting, diarrhea, and flatulence. Some people even experience constipation, and these usually subside with time. However, some patients continue to have severe GI side effects that may make them discontinue metformin. If a patient develops severe GI side effects on metformin, such as diarrhea, you can trial them on the extended release version, as it has been shown to have fewer GI side effects when compared to the immediate release version. The other major side effect, though rare, is lactic acidosis. This happens when lactate builds up in the blood. Levels greater than 5 micrograms per ml can be fatal. Patients with lactic acidosis may complain of malaise, abdominal pain, respiratory distress, and other non-specific symptoms. Patients with diabetes-induced lactic acidosis should undergo prompt hemodialysis to reverse the symptoms. As a result, metformin should be discontinued when conditions that put patients at risk for lactic acidosis present, such as those needing iodinated contrast media, patients with an EGFR of less than 30 mL per minute, patients with congestive heart failure, and patients with any conditions that cause hypoperfusion or hypoxemia. So just to recap, metformin is the only FDA-approved biguanide to treat hyperglycemia in the United States. It is the drug of choice for use in prediabetes and type 2 diabetes. It has many benefits, including potential weight loss, a reduction in the risk of MIs and all-cause mortality. It has new prescribing guidelines that can benefit those with reduced renal function. It has major side effects, including B12 deficiency, GI side effects, and rarely lactic acidosis. This brings us to the end of our discussion on biguanides. I hope you enjoyed it. Until next time, have a good one.